I'd like to welcome everyone to the Vasculitis Foundation webinar today. I'm Kathy Olewski, the host for the Vasculitis Foundation's educational webinar series. I'm also a patient living with MPA vasculitis. And today we're talking with Dr. Villaforte to ask questions about vaccines while living with vasculitis. These webinars are part of the Vasculitis Foundation's commitment to patient education, and we'd like to thank our sponsors, AstraZeneca, Amgen, and Novartis, for supporting these webinars. And of course, we're grateful to Dr. Villaforte who's with us today to answer the questions that the patients have sent in about vasculitis and vaccines. So let me begin by introducing Dr. Villaforte. Dr. Alexandra Villaforte is a staff physician at the Center for Vasculitis Care and Research at the Cleveland Clinic. She's an associate professor of medicine at the Cleveland Clinic Lerner College of Medicine in Cleveland, Ohio. So welcome, Dr. Villaforte, and I'm happy to have you here. And also I'd like to ask if you have any disclosures that are relevant today, if you'd like to tell us those things.
Oh, I'm very happy to be here. Thank you so much for the kind introduction, and I'm happy to address these very important questions and help in any way I can. The main disclosure that I would like to give today is that some of the questions we're addressing today are not necessarily based on hard data, but I'll give some of my experience and my own opinion, and I'll make clear of that. I'm also a consultant for Amgen, but let's go ahead and get started.
Great, thank you. So these questions, as we said, have been sent in by patients, and we've done our best to consolidate them into the ones that you can answer for us today. And I'll start with the first one. Can you bring us up to date about the COVID vaccination recommendations? What is the latest information we need to know to make sure we're protected?
Okay, I can understand how confusing this is at this point, and knowing what the vaccines are available and what to do about doses and which ones to have has been a very confusing field with different opinions about it. So I'll talk a little bit about what the CDC is recommending and what we're actually doing in practice. We borrow some of this knowledge from the CDC, but the most important thing is to know that each person is in a different situation, in a different case, and the rules don't apply the same to everyone. So individual decisions have to be made between physician and patient. In summary, there are two types of COVID-19 vaccines that are recommended in the United States at this point in time. Two vaccines are the messenger RNA vaccines. One is the Moderna, and the other one is the Pfizer. And there's the third vaccine, which is not a messenger RNA vaccine, is a protein subunit vaccine. It's called Novavax, and we'll talk a little bit more in details about it. That was recently emergently approved. So the Moderna and the Pfizer are well known by all of you. They're authorized by the FDA for children ages 6 months and above, and adults, obviously. And they have different names. The Spikevax is the licensed Moderna product for people age 12 years and older. And the Comirnaty, which I'm not even sure I'm pronouncing this correctly, but it is the licensed Pfizer product for people ages 12 and older. But as a total, they are known as the Moderna and the Pfizer. So I know that there was some confusion with the names. The Comirnaty is a Pfizer vaccine. It's not a different kind of vaccine. The Novavax is different. It is a protein subunit vaccine. It means that it takes a protein and it stimulates the production of autoantibody. And this protein is from the spike protein of the COVID virus. It is very similar. It's the same kind of vaccine, for example, that is used for hepatitis B and the shingles. So it's been used for many decades. And some people have felt more comfortable now with the approval of this one. Trying to explain a little bit about the CDC guidelines, which have been a source of confusion. So the CDC divides the guidelines based on group of people who have never been vaccinated and have never had COVID, although they don't specify that. And they divide it in the second group of people who have received some kind of vaccinated in the past and may be delayed on getting boosters, and what should they do now that they decided to get another dose, but they've been vaccinated before. So it's complicated, but trying to make this very simple. If someone has never been vaccinated ever, the CDC recommends for older adults and for immunosuppressed adults that they received actually 3 doses. They're consecutive. They are about 8 weeks apart for the Moderna and 3 weeks apart for the Pfizer, and then a 4th dose that is 6 months later. Well, let me tell my take on that, and you probably know that that's not being done very frequently. Is that because the situation of unvaccinated people that have never had COVID before is very rare, actually. We don't find people that fit in this category very much. The majority of people have had at least 1 dose of the vaccine, even if many years ago. So what is happening in practice is that most people are being recommended to get 1 dose of either the Moderna, the Pfizer, the Novavax, and the 2nd dose 6 months later. Now, the 2nd dose can be given even as early as 2 months, but at least 2 months after the 1st dose. But more commonly, we're seeing the 2nd dose being given 6 months after the 2nd dose. So the series as being recommended by the CDC with 3 consecutive doses before the 4th dose that is 6 months later is rarely being done. So I don't want anybody to be thinking that their doctors are doing something wrong, but it's just very difficult to apply that to every single individual, especially because most people have had COVID. So in general, if you have received 1 dose, you should receive, if you are immunosuppressed or older than 65 years old, you should receive a 2nd dose at least 2 months later, but most of the time it's being given 6 months after that. And lastly, the most important thing, people with vasculitis are in different treatments, and sometimes there are no treatment at all. Depending what kind of treatment someone is on, this recommendation may change. So timing of the vaccine also needs to be adjusted for what's happening to that person's disease, but also based on the treatment. So between you and your doctor, you should come up with the best adjusted time and not be so rigid about the CDC rules that don't apply to all of our situations in the vasculitis world.
Okay, so it sounds like I hear everything you're saying, and it sounds like one of the best things you can do is communicate with your provider about when you are due for a booster and how to work it around whatever medications you're taking at the time.
Yes.
I have a couple of questions about that. One of them is the Novavax, which is fairly new, that's safe for immunocompromised patients?
Yes, all 3 can be taken and should be taken. It's safe for immunosuppressed patients. The ingredient that is used is called an adjuvant. That is a protein, and that is safe for people who are on immunosuppressive medications.
Okay. And another question that I thought of for me is if you've had COVID and you're due for if you've had COVID recently and you're due for your booster, I think one doctor told me no need to worry about waiting, just go ahead and get the booster. And one doctor told me wait 3 months because I was essentially boosted because I had COVID. So do you have an opinion on that, or does the CDC have an opinion on that?
The CDC is not putting an exact date or amount of time to wait because of the different situations and scenario, depending on how intense the immunosuppressive therapy is at that point in time. So I think people who are at a higher risk might receive the vaccine, the booster, earlier, maybe even 1 month after having had COVID. Most people are waiting about 3 months. But again, it depends a lot. For example, if someone is on rituximab, which is a drug that has a major impact on the efficacy of the vaccine, then we need to be very careful about timing the COVID vaccine to their dose of rituximab. And that plays a role in deciding even if they have had COVID.
Okay. And One question we got is there a new vaccine that combines both the flu and COVID vaccines in one shot? And if there is that safe for an immunocompromised patient to get both the COVID and influenza shot in the same visit?
That's a great question. I believe they are on clinical trials now. They are, but I think it's the phase 2 going on phase 3. So the combined vaccine, COVID plus flu, is not yet available, but is on an ongoing phase 2 or phase 3 trial. So I think that will be in the future and making it much more convenient. It would be safe for immunosuppressive people and having both, which means that they can have both on the same visit at this time.
Okay, great. That's good to know. And can you talk briefly about Pemgarda, if I said that right?
Okay, you did. Yes, that's a major source of confusion. It is a monoclonal antibody, and the whole idea is to protect against COVID before exposure to COVID. So it's not indicated for the treatment or for post-exposure situation. It is for people in a situation of very high risk for COVID and need additional protection. For example, people who are undergoing chemotherapy for cancer or intense immunosuppressive therapy, and maybe in a situation where they, for some reason, could not get the vaccine, although that's not specified with this monoclonal antibody. The recommendation would be that if someone chooses to receive the Pemgarda is that they would be vaccinated as well. So a few problems that happened, and it were the same kind of problems we were facing when Evusheld was available. As we all know, the virus mutate. So we don't know for how long the protection with Pemgarda will be in place. If the virus, let's say, mutate within 3 months, the person might be at risk again despite having received Pemgarda. So there's a question of efficacy of prevention in terms of virus mutation, which that's what happened with Evusheld in the past. It became no longer an important tool in prevention. Someone would have to receive a dose about every 3 months to make sure that they are protected by Pemgarda, so it doesn't necessarily last beyond 3 months. So there's issues with availability, issues with cost, issues with deciding who are the people who would benefit most from it, and timing of use as well. So there are a lot of obstacles, and a lot of doctors have not been relying on using it. So I think there should be a conversation between the patient and the physician about pros and cons of a little bit of a complicated resource.
Okay, and I think you covered this, but just to be clear about it all, we have a couple of questions that go together. One of them is, should a person receive the COVID vaccine while vasculitis is active? But you've already said we should be getting the vaccine, but the next one is, when is the best time to get any vaccines during treatment for vasculitis? So those are two different things. Vasculitis can be active, and your treatment, like, I mean, I have vasculitis, but I'm not under any treatment right now. I'm off treatment. So I'm just saying is the people that are on treatment probably are more concerned about how to time that. I think your answer was talk to your provider about that, but maybe you give us the guidelines we should understand.
Be happy to. There are two issues in your question there. One is someone who has active disease. So let's take that person who was recently diagnosed and is not on treatment. So the ideal time, if they're not up to date with their vaccine for COVID, is that they receive the COVID vaccine and all the other vaccines that are necessary before treatment. Mm-hmm. So for the great majority of vaccines, we would like to vaccinate at least 2 weeks or about 2 weeks before starting treatment, so that we increase the efficacy of those vaccines. And for the COVID vaccine, if using rituximab, ideally 4 weeks before, 3 or 4 weeks before. But let's say we don't want to delay treatment. Someone is very sick. We should not delay treatment so that we can get the vaccine in place. We should vaccinate it and start treatment as soon as we decided that it is necessary. So one person may find themselves in a situation where they have to receive the vaccine and immediately start treatment. So I am not concerned about having the vaccine while the disease is active, because that's the moment we want to protect everyone. That's actually extremely important because we're about to start an immunosuppressive medication. So no concerns there. The second person is whether they have active disease or not, they're already on treatment. And maybe they are intensifying their treatment because they're having a flare-up, or maybe they're just on their maintenance therapy and they want to time the vaccine. So let's take the person who is in remission, doing very well, and is in the maintenance therapy, for example, with rituximab every 6 months. So timing is very important to increase the efficacy of the COVID vaccine. I tell my patients to receive their booster 3 to 4 weeks before the rituximab infusion. And this way they can have the COVID booster every time before they are due for the next rituximab. Since the CDC guidelines actually recommend that is given at least every 6 months for immunosuppressive patients, we can time that with the rituximab, which is usually given every 6 months. So that would be easy if we can put that in place and increase the chances that the vaccine work better.
Okay, I think that was very clear. Thank you. That helps a lot. The next question is about RSV. First of all, what is RSV? Should immunocompromised patients of all ages get the RSV vaccine, or just patients over the age of 75? And if you received an initial RSV vaccine, are additional doses required?
So RSV, or respiratory syncytial virus, is a very common respiratory virus, actually. It gives like causes an infection of the nose, throat, and lungs, upper respiratory infection. It's very difficult to distinguish RSV from a common cold or even COVID itself, or any virus that causes respiratory symptoms. It can be a very serious disease, leading even to death in very early ages, like less than 6 months, and older adults. RSV is very seasonal. It spreads in the fall and the winter, when is most of the respiratory viruses. So it's important to time the vaccine to late summer, early fall, just like the flu shot. It usually peaks like December and January in the United States. The CDC recommends a single dose of the RSV vaccine, of any of the FDA licensed RSV vaccine, for all the adults, they're age 75 or older, if healthy, and all the adults age 60 and older if they had an increased risk of severe RSV. And that includes all people who are immunosuppressed. So for immunosuppressed adults, the recommendation is that they receive the single vaccine if they're 60 years or older. The RSV is only one vaccine. At this moment, we don't have any recommendations that it needs to be repeated. So if someone has been vaccinated one time, they don't need another dose. At this point, the recommendation might change, but that is what's the current recommendation. It can be received at any time if you think that someone is about to start treatment with immunosuppressive medications, but ideally should be given at around the same time when we're getting the flu shot. It's not currently an annual vaccine. It is just a one-time. There was a little bit of a panic last year as we started to recommend to all our patients immunosuppressed ages 60 and older, and there was not enough vaccines. They were not available. There was a lot of confusion last year, and some places refused to give because they were not 75 years old, and the guidelines were not that clear to all the pharmacies, but there was not enough. So this year is a little bit better. So for those who have not been vaccinated last year when it came out, they should search for their availability. This is a good time to get it now still, even though it's a little bit past. I think that if you've never been vaccinated, you're older than 60 and immunosuppressed, you should receive, because it can be potential very serious respiratory infection.
Okay, and the bonus question for that, say you're going in to get your flu shot in the fall of the year and you have never had RSV vaccine. Can you get your flu shot and your RSV at the same time? I know you said you could do COVID and flu at the same time. Can you add RSV on there, or is that too many, or what should you do?
You can add and you can have them all. Some people will say that you are at increased risk of having a little bit of some of the common mild side effects because you combine vaccines that have the same kind of side effects. Some people get a little bit of a sore throat, a little low-grade fever, some flu-like symptoms for 1 or 2 days when they have the flu shot every year. That can be a little bit more intensified if you're having 2 or 3 vaccines that have the same kind of side effects. They're very similar. And that's a good point that you are bringing up. The Novavax, I don't want to give the wrong idea that is safer than the Pfizer Moderna. That is not true. The Novavax has similar actually side effects and the same concerns, which is rare, but the same concerns with the pericarditis and myocarditis as with the Moderna and Pfizer. The risks of those complications are the same for the Novavax, even though it's not a messenger RNA. So I just don't want anybody to be running and panicking, thinking that that's the best vaccine. They should get that because they're at a lower risk. That is not true. And that's why the recommendation for all of them is that the booster should be given not before 2 months after the first dose because of that risk. So if you space it out, the vaccine, whether it's the Moderna, Pfizer, or Novavax, by at least 2 months, then the risk is very low for all of them.
And are we thinking that we're going to be taking a COVID booster every 6 months now, forever, or?
That is just a recommendation for immunosuppressed.
Okay.
At this point. So the booster 6 months later is for a particular group of people who are at a higher risk of having more severe COVID.
Okay, I understand. And as long as we're talking about COVID here for a second, when you get COVID, you also, if you see your doctor quick enough, you sometimes get Paxlovid, if I said that correctly.
Mm-hmm.
Are there any special circumstances for immune compromised patients to take the Paxlovid? Is there anything wrong with, is it a risky thing at all? Or is it good?
This is an excellent thing. I'll give you my own opinion about that, but it's based on also the recommendations. So all people who are immunosuppressed should receive Paxlovid if they get COVID, no matter how severe is the infection, no matter how severe the symptoms, unless they have a contraindication for Paxlovid. I'll give an example of that. If someone is taking a medication that can be stopped for those 5 days while they're on Paxlovid, I would rather do that. So, for example, there are certain medications to lower cholesterol that have an interaction with Paxlovid. So I just tell my patients, stop taking your Lipitor or any other medication that can interact with the Paxlovid as long as it's safe to do that. If there is a medication that is absolutely necessary, cannot be stopped for those 5 days, then they should not take Paxlovid. Mm-hmm. That's rarely a situation that we encounter. So independent of how severe are the symptoms, Paxlovid decreases the chance of having more severe COVID. So it should be considered for everyone who is immunosuppressed.
Okay, and last question is about all the other vaccines. Like, as an immunocompromised patient, should I be taking shingles? The Shingrix or whatever the vaccine is for shingles? Is there anything else that I'm not thinking of should I have the pneumonia vaccine? How often do I get those other ones? Can they go in combination? Like, I don't know if I should walk into my pharmacy and say, I want COVID, I want flu, I want RSV, I want shingles, I want pneumonia. What should I do?
Well, that's a great question. So very important point for everyone, independent if they're immunosuppressed or not, the great majority of vaccines will follow the age recommendation. So even for immunosuppressed patients, we don't start giving all the vaccines for any age just because we think that they'll be at a higher risk so we can protect them. There are certain vaccines that cannot be given below certain ages and independent of the person being immunosuppressed or not. So as a general statement, we follow the age recommendation for the majority of the vaccines. Now, maybe how often we give, for example, the COVID, that is different based on immunosuppression or not. That is an extra dose. But the vaccine for pneumonia, the vaccine for the flu, the vaccine Shingrix for shingles, those we follow the age-based recommendation and the guidelines are the same. The important thing is to start, if possible, get these vaccines all before starting treatment. So vaccines works better if they're given before an immunosuppressive therapy is started. But having said that, I also don't want to give the wrong impression or the wrong recommendation that any treatment should be delayed when it can't be delayed just because you need to get your vaccines. So do everything at the same time if that's not possible to wait.
Okay, I think we've asked you all of our questions. Is there anything else that you would like to add in there that you haven't said about maybe things that you do in your practice, or have we covered them all?
I think I'll answer one question that I get a lot.
Okay.
And I think that's an important question for people, especially if they're not taking rituximab, they're taking other drugs such as mycophenolate mofetil or the Cellcept, methotrexate, azathioprine. So drugs that we use commonly. And if you look at the American College of Rheumatology guidelines, for example, for the methotrexate, they'll say hold the methotrexate 2 doses before you get the COVID vaccine. Well, that's not true and does not apply to everyone in the rheumatology world. And most of patients with vasculitis cannot afford to stop their therapy for 2 weeks or longer so that they can get a vaccine because they're facing the risk of a relapse. So we should make recommendations based on the risks of every person. So there will be patients that I recommend them not to stop, even though at the American College of Rheumatology it says that's the guidelines, but those guidelines don't apply the same way for everyone. So talk to your doctor if it's safe to stop any medications before getting any vaccines, even if your disease is in remission. That might be a high risk that they don't want to recommend for you.
Okay, thank you for that final point. And I think at this point, what I would love to do is just to say thank you so much to Dr. Alexandra Villaforte for sharing her time with us today and answering our questions. Thank you to the Vasculitis Foundation for always supporting the patients with these educational webinars. And thank you to our sponsors, Amgen, AstraZeneca, and Novartis.
And thank you for having me.